So we've always known AML to be a very heterogeneous disease. For years, we've been using chromosome analysis, karyotype analysis to differentiate between different prognostic subgroups. With the advent of next generation deep molecular sequencing, we've been able to uncover several different mutations in AML that are recurrent, somatic mutations, that we know not only give us ideas about the prognosis, but also potentially can offer targets that we can use with newer targeted therapies in these patients. For example, in terms of prognosis, we know that mutations in things like P53, FLT3 or FLT3 are very important predictors of negative or adverse prognosis. In terms of P53, recent studies have shown that low-intensity therapy may be as good in terms of response rates in these patients and may provide equal or even better survival in these patients with much less toxicity. And so these are important advances that we need to think about. Things using like 10-day decitabine or cladribine and low-dose C, low-intensity therapies in patients with P53 mutated AML. In addition, FLT3, which confers an adverse prognosis, also has numerous FLT3 inhibitors that have been developed over the past several years. At this year's ASCO meeting, we have a very interesting abstract using gilteritinib, which is what I would say a third or fourth generation FLT3 tyrosine kinase inhibitor, which is both a type 1 and type 2 inhibitor, meaning that it affects both FLT3 ITD mutated patients and FLT3 D835 mutated patients. And what they showed very nicely is that you can actually measure the allelic frequency of FLT3 before treatment and then during treatment. Those who had the deepest molecular response had that correlated with the best overall survival. So that's one. Second, there's mutations in genes called IDH1 and IDH2, which are very important in the metabolism of AML cells. They create an oncometabolite called 2-hydroxyglutarate. Companies have developed inhibitors of IDH1 and IDH2. The furthest along is the IDH2 inhibitor, AG221. An abstract has been presented at this ASCO meeting as well, demonstrating significant response rates of 30 to 40% in patients with relapsed and refractory IDH2 mutated AML as a single agent. The responses occur quickly and they are durable and they evolve over time. So a patient who may have stable disease or just a partial response in the first few months eventually transition to a complete response and they remain in remission very durably. They showed excellent tolerability, a small incidence of differentiation syndrome, which can be easily managed by people who recognize it with corticosteroids, etc. Finally, the mutations not only can be prognostic, not only can be used for targeting therapy, but a very nice abstract by Dr. Takahashi and colleagues from MD Anderson showed that you can actually detect the mutations not only at baseline, but during treatment with intensive chemotherapy. And you can look at the clearance of mutations over time, and he looked to see whether or not this correlated with improved outcomes. Indeed, clearance of mutations did correlate with improved relapse-free survival, but did not correlate with overall survival. Deeper sequencing technologies where you can detect mutations at really low allelic frequency may be better at delineating who's going to relapse, who's not going to relapse, and who will predict for better overall survival. So I think the molecular revolution in terms of deep sequencing has really taken us to another level and a new generation of treatment of AML, where we're moving away from just treating everyone the same way, but more individualized.